So very good morning, students. I hope you are maintaining the social distancing as I had advised you earlier and maximizing your learning. So we are here to continue with the learning process. As I told you, the learning is limitless. It doesn't have any boundaries. It doesn't have, you don't have to learn going out of the house. So these things we can practice at home. So coming to the spinal sites of action of opioids, in the last session I dealt with the classification of the opioids based on the source of their origin, classifying them into natural, semi-synthetic, and of course synthetic ones. Then I also told something about the endogenous opioid peptides, which are very, very important and they are naturally released in the body. And we dwelt a little bit more on the receptors for these opioid agonists, which are basically mu, kappa, and delta. So we had read about these actions, and as I told you that this receptor is abundantly present in the spinal cord as well as the brain. But also we discussed they do have peripheral presence, in that they are present in the GIT and the urogenital tract. So continuing with this knowledge and building more knowledge to it, let us proceed further, students, into the sites of action of these opioids. You know that these opioids, they act on the opioid receptors, which are G protein coupled receptors, and as I already told you, the receptors are scattered in the brain as well as the spinal cord. So coming to the ascending pain pathway, this is the mechanistic flow diagram of tissue injury evoked nociception. As you know that tissue injury brings about a the release of prostaglandins, bradykinins and other kinins, they making a major nociceptive input, and the peripheral analgesics like NSAIDs, they block the production of prostaglandins. So following the tissue injury, there is local release of active factors and there is activation and sensitization of A delta and C fibers, which are the pain fibers, and that leads to the ascending transmission of pain and spinal facilitation and causing exaggerated output for given stimulus input, leading to ongoing pain and hyperalgesia. So we have to presume that the opioid receptors, they are present in the ascending pain pathway where they inhibit the ascending pain transmission. If you see how they inhibit it, these are the spinal sites of opioid action, mu, kappa and delta agonist. They reduce the transmitter release from the presynaptic terminals of the nociceptive primary efferent. This is the first order neuron. This is the second order neuron, and these agonists, they decrease the release of the transmitters, the pain producing transmitters, by coupling with the GI, decreasing the production of cyclic AMP, and that leads to inhibition of the calcium ions. So calcium cannot come in, and that is a result, there is decreased neurotransmitter release. And not only they decrease the calcium influx via decreasing cyclic AMP, the mu agonist also hyperpolarize the second order pain transmission neuron by increasing the potassium conductance, and potassium conductance brings about a state of hyperpolarization and generation of inhibitory postsynaptic potential. So the pain transmission is terribly interfered with by the opioids, both at the level of primary efferents as well as the second order pain transmission neurons. So this is the mechanism of action of the opioids. This diagram also actually conveys the same meaning, and this is the mu opioid receptor. This is the primary efferent fiber. This is the periphery. This is the pain stimulus which is carried on by the nociceptors, and the mu opioid receptors which are stimulated by the opioid agonist. See, they are abundant in nature, the mu opioid receptors, and these mu opioid receptors, when they are occupied by a mu agonist, they decrease the cyclic AMP and they inhibit the influx of the calcium ions. So if the calcium ion influx is interfered with, there is going to be less release of the neurotransmitters here, the glutamate or the neuropeptide. Here I would also like to mention the role of the alpha-2 agonist. You know, the alpha-2 is a autoreceptor which is inhibitory in nature, and its stimulation by clonidine or dexmedetomidine or any such drug which is an alpha-2 agonist is also going to inhibit the release of the neurotransmitters. So, you know, clonidine-like drugs, they are also given as pre-anesthetic medication. They might be given like for analgesic effects also, because they also inhibit the release of the neurotransmitters by acting presynaptically. And if these pain-producing neurotransmitters are produced, they are released, they are going to act on the NMDA receptor, the neurokinin receptor, stimulate the secondary efferent neurons. But here also the opioids, they apply a big break. You can see the presence of the mu opioid receptor here, and stimulation of the mu opioid receptor here by morphine brings about opening of the potassium ion channels, bringing a state of hyperpolarization and inhibitory postsynaptic potential. So students, the ascending pain transmission is terribly interfered with, and that is one of the unique features of these opioids, that they can bring about the relief from pain. So this is the way they act at the molecular level. These are the putative sites of action of the opioid analgesic. So this is the ascending pain pathway which is shown in this figure. So the first order neuron from peripheral afferents to the dorsal horn substantia gelatinosa of the spinal cord, and then the second order neuron from the substantia gelatinosa to the spinothalamic tract, the third order neuron from the spinothalamic tract to the ventral and the medial thalamus, and medial thalamus also sends projection to the somatosensory cortex. So here we will have abundance of the mu receptors, and the pain transmission would be inhibited. Now the opioids, we say that they inhibit the ascending pain transmission, and they actually stimulate or modulate the descending inhibitory pathways of pain. They cause stimulation of these descending inhibitory pathways. So as a result, patient feels less pain, which starts from the somatosensory cortex to the midbrain periaqueductal gray matter. Midbrain and brainstem produce significant inhibitory effect on transmission of the dorsal horn. And the descending inhibition is mediated by two neurotransmitters, 5-HT noradrenaline primarily, followed by adenosine. And if you want to sum up, the opioids, they produce analgesia by facilitation of the inhibitory descending pathways by acting at the periaqueductal gray, inhibition at the thalamic site, inhibition of the dorsal horn transmission, and inhibition of the excitation of the peripheral nerve endings. So this could be the mechanism of action of opioids in a nutshell. These are the ascending pain pathways which are inhibited by opioids. Of course, at the beginning level where there is a nociceptive involvement, that is inhibited by aspirin and other non-opioid analgesics. But you know, as the pain pathways go to the higher structures, it is the opioids which come to the rescue, that they inhibit the ascending pain transmission. The descending inhibitory pathways, it is shown here, is activated by the opioid analgesics, conferring a great pain relief to the patient. So this is also what I talked about earlier, that the morphine-like drugs, they occupy the mu receptor, any opioid receptor, and couple via GI, and that would inhibit the production of cyclic AMP by decreasing the concentration of adenyl cyclase. And decreasing the concentration of adenyl cyclase is going to block the calcium entry and is going to hyperpolarize the membrane by opening the potassium ion channels and finally leading to decrease in the release of the neurotransmitters. So when you administer opioid systemically, the actions are multifaceted. They act simultaneously at multiple sites. Not only the ascending pain pathways of pain transmission, but also leads to activation of the descending inhibitory neurons that send processes to the spinal cord and inhibit the pain transmission. And students, if you recollect from my previous session, the part of the pain relieving action of the exogenous opioids involves the release of even the endogenous opioid peptides, the endorphins, the dynorphins, and the enkephalins, and both the exogenous as well as the endogenous opioids, they confer or they have a synergistic action as far as the pain relief is concerned. Now coming to the pharmacological effects of opioids, the very purpose actually we are giving the drug for is for the pain relief. It's a relief of pain without loss of consciousness. When I'm telling this statement, student, it means that we are trying to compare it with the local anesthetic, with the general anesthetics, because they also bring about pain relief, but they bring about a loss of consciousness. So morphine, the consciousness is little bit, the patient might feel drowsiness, sedated, but he is fully conscious. Patients are still aware of the presence of pain, but the sensation is not unpleasant. I told you that pain brings about emotional symptoms, it brings about autonomic symptoms too. And you know, with the pleasure producing properties of morphine, whatever pain the patient feels, he is able to absorb it better, able to perceive it in not so unpleasant way. The sedation by morphine-like drugs is different from hypnotic drugs because, you know, hypnotic drugs can offer higher grades of sedation in the form that initially they are anxiolytics in nature, but as you keep on increasing the dose, they cause sedative effects and then they can cause depression of the medullary centers also. So this sedation, this amount of sedation is not brought about by the opioids. Of course, there is drowsiness associated with the use of morphine and clouding of mentation. But you know, as you keep on using the drug morphine, body develops tolerance to these central nervous system effects. Tolerance develops to the bad effects of morphine also. Tolerance develops to the analgesic or the most beneficial effect of morphine also. Body doesn't differentiate between two effects, but the patient starts again to feel the pain with his regular dose of opioids until so much so that he might need larger doses of opioids or might need a different opioid for pain relief. So why morphine is unique? Because when pain does not evoke its usual responses, I told you anxiety, fear, panic and suffering, a patient's ability to tolerate the pain may be markedly increased. Coming further to the central actions of morphine, morphine produces a powerful sense of euphoria, contentment and well-being. And that is the reason its use has not been able to be curtailed. It is a drug of abuse and it can be procured via illegal suppliers also. And you know, the drug addicts, they might not be falling in place where their peers are. So, you know, not having too much of peer pressure or feeling that we will not be able to match up to the expectations of the society might drag such individuals to drug addiction. So that urge should be resisted, and efforts actually students should be made to perform well in life and to fight against any adversity rather than resorting to such drugs. And of course, where there is euphoria, there is activation of the reward pathways, and these reward pathways are basically dopaminergic pathways which involve the nucleus accumbens. Now coming to the respiration. Now the effect of morphine on respiration is something which is uncalled for, because morphine might not affect the consciousness of a person, might not produce such severe grades of CNS depression from hypnosis to coma to death, but students, it can inhibit respiration at therapeutic doses. And that is one of the reasons of death associated with morphine users who are legally prescribed morphine for their pain relief, and morphine abusers also. So morphine-like drugs, they are respiratory depressants in nature. They selectively depress the respiration. They not only suppress the hypoxic drive to respiration, but they also suppress the hypercapnic drive to respiration. And mind you, this occurs at therapeutic doses. It is the direct effect of these drugs on the brainstem respiratory center, and they depress all phases of respiratory activity. The rate of respiration decreases, the minute volume decreases, the tidal exchange decreases, the rate of breathing falls to 3 to 4 beats per minute. And you know, a respiration, if the person will breathe when he is asked to breathe, otherwise his respiration rate would be very, very low, 3 to 4 beats per minute. It also reduces the sensitivity of the respiratory center neurons to carbon dioxide, which is one of the major stimulus for breathing. They depress the ventilation otherwise driven by hypoxia. And I want to add here that if you are giving the opioid systemically, either intravenously or more so if you are giving the intravenous, if you are giving the opioids via the spinal route, epidural opioid therapy, then there are effects which are seen on the chest wall also, that there is mechanical effects on airway function by increasing, because the opioids, you know, they increase the chest wall rigidity, and this is also a spinal action which is seen more if the opioids are given via the subdural, or they are given into the subarachnoid space. This is the type of thing which is seen, that is a mechanical effects on the person, and that itself decreases compliance as well as causes the chest wall rigidity. And I want to also add here, although we have not yet touched upon it, that morphine like drugs are histamine releasers in the body, and you know histamine produces bronchoconstriction. So all these effects of morphine get added up. Which effects? First is direct depression of the brainstem respiratory center. Second is the mechanical effects. The chest is not able to expand well. And the third is that morphine-like drugs bring about bronchoconstriction, and that is going to further decrease or increase the problem of breathing in a person. So this effect, students, you must remember, is one of the most uncalled for, unwanted effects of opioid therapy. If you get analgesia, you get associated inhibition of respiration. There are some factors which exacerbate opioid-induced respiratory depression, and if we just think about which are those factors, person already having a history of COPD, chronic obstructive pulmonary disease, person already having bronchial asthma, because it's a histamine releaser, morphine-like drugs, they will contribute to bronchospasm. Elderly, because they might be subjected to more respiratory depression as compared to their younger counterparts. Neonates, for example, they might, if the lady takes opioids for relief of pain of childbirth, the patients will have, or the neonates which are born will have respiratory depression. So let us go to the factors which exacerbate this opioid-induced respiratory depression. Of course, if the patient is also on other medications which can be combined with opiates like the other CNS depressants in the form of antidepressants or sedative hypnotics, or he is taking alcohol daily. Alcohol, is a CNS depressant. You must understand that alcohol combined with other CNS depressant might produce severe degrees of CNS depression, which could be lethal to a person, or tranquilizers in the form of antipsychotic agents. They are called the major tranquilizers, although we have not stopped using this term any longer. Natural sleep and depressant effect of morphine is additive, okay, and especially obstructed sleep apnea, that is a condition where the upper airways, the laryngeal muscles, they will obstruct the breathing of a person, especially seen in patients who are obese, and it increases the chances of fatal respiratory depression. Newborns and elderly are at a greater risk of depression because of reduced lung elasticity in both the group of individuals, chest wall stiffening, especially in the elderly, decreased vital capacity in extremes of age. If there is already associated COPD or bronchial asthma, we might have more respiratory depression. And of course, the morphine-like drugs, they bring about relief of pain, because pain stimulates respiration itself. Removal of the painful condition reduces the ventilatory drive, and there is an apparent respiratory depression. Students, just remember this thing. Now coming to the central actions of the opioids, to continue further, till now we have read about the analgesic action, we have read about the euphoria producing action. These days everybody wants to have that goodwill feeling, which somehow we are not able to get because of the impending pandemic. We keep on having the stories of healthcare workers who are not having any personal protection, not only in a country like ours, but in a country like America also, where the COVID epidemic has taken a lot as with respect to the death toll and with respect to the healthcare costs. That everybody wants to feel good from inside. Some good news should come from somewhere. So everybody wants a sense of euphoria. So second action of morphine is a sense of euphoria. And the third action which we discussed was not such a good action, was a depression of the respiratory center. Morphine does have other stimulatory effects on the central nervous system also that we are going to discuss later. It causes sedation, it causes a sense of angiolysis, and that is brought about associated with drowsiness, lack of interest in the surroundings, apathy, there is cognitive impairment to some extent, of course body gets used to it, and a sense of tranquility. Morphine depresses the cuff center also, and opioids, they suppress the cuff center in the brain. And I told you the naturally occurring opioid, codeine, is a very effective antitussive agent. It is in fact one of the most important centrally acting antitussive agent because its antitussive effects are seen at much lower doses than its analgesic effect or its respiratory depressant action. It has an action independent of opioids as far as suppression of the cuff center is concerned. Here I am talking about the drug codeine. So morphine and codeine and all other opioids, they suppress the cuff center in the brain. As far as their other stimulatory actions on the brain are concerned, morphine excites the Edinger-Westphal nucleus, which is the nucleus of the third cranial nerve, the oculomotor nerve, and the patient develops pinpoint pupil. Not only the patients, even the drug abusers, they develop pinpoint pupil, and this constriction of the pupil, the patient does not develop tolerance to this action. So even if he is a morphine abuser who has been using morphine for a long time, his pupils will always be pinpointed, and that is one of the criteria to decide or to exclude morphine overdosage or morphine poison. There is little tolerance to the effect of this pinpoint pupil, and all morphine abusers, as I told you, demonstrate the pinpoint pupil, and it is because of the enhanced parasympathetic stimulation to the eye. As far as stimulation of the other centers in the brain and the spinal cord are concerned, the morphine-like drugs, they also stimulate the chemoreceptor trigger zone. Of course, that lies outside the blood-brain barrier, and it causes nausea and vomiting. So these are some of the effects of morphine, and this picture shows a typical pinpoint pupil of a morphine user, because the pupil doesn't return to a original size because tolerance doesn't develop to the pinpoint action of morphine. So let us have this mechanism action related MCQ for you students. Morphine produces an analgesic effect due to what? A block of the potassium efflux from a neuron, increase in the cyclic AMP accumulation in the neuron, a decrease in the intracellular calcium in the neuron, interaction with the GS protein in the neuron. Which is the correct answer? Let us see from option down. It is interaction with the GI protein. No, I told you it is the interaction with the GI protein, not the interaction with the GS protein. So this is an incorrect statement. Then we discuss this point A. Does it block the potassium efflux from the neuron? No, actually it enhances the potassium efflux from the neuron, and that brings about hyperpolarization and generation of inhibitory postsynaptic potential, especially in the second order neuron. It does not decrease the cyclic AMP accumulation. It actually decreases cyclic AMP formation via decreasing the production of adenyl cyclase. What it does is a decrease in the intracellular calcium in the neuron, and that decrease is mediated by factor 2, if it would have been written correctly, a decrease in the cyclic AMP. So that decreases the intracellular calcium in the neuron. So this is the third option is the correct option. Morphine also stimulates the vagal center in the brain. It causes bradycardia because of enhanced parasympathetic effects. It causes truncal rigidity. As I told you, this is one of the limiting factors, and it contributes to the respiratory depression, which is brought about by the use of systemic morphine-like drugs. And morphine not alone, it's not a CNS stimulant so much that it is going to cause convulsions. Actually, morphine-like drugs, when they are taken in by a person, morphine produces one metabolite, which is morphine 3-glucuronide, not morphine 6-glucuronide, students, morphine 3-glucuronide. And this morphine 3-glucuronide does not have analgesic activity. Morphine 6-glucuronide just has analgesic activity. It contributes to the analgesic effect, but morphine 3-glucuronide does not have any analgesic activity. It just crosses the blood-brain barrier and it causes convulsions. So that is the reason for morphine causing convulsions, and some other opioids also causing convulsions, and the pethidine and meperidine, they also produce a metabolite which is causing CNS excitation and which can lead to the development of convulsions. Nothing is, concrete. There are always exceptions to the use of morphine, because there have been some studies recently which have demonstrated a paradoxical effect of the opioids, that they, instead of bringing pain relief, they cause hyperalgesia. And this may happen after persistent administration of opioid analgesics and involves the activation of the bradykinin and NMDA receptors. Of course, this the researchers have not been able to explain to the scientific world, but this has been observed. Hence, use in chronic pain is controversial. Chronic pain use might invite respiratory depression. It might invite physiological and physical dependence, and they say that chronic pain can sometimes be managed effectively by the use of NSAIDs. So let us have this when we'll discuss the WHO pain relief ladder. At that point of time, I think we'll be more clear about it. So coming to the peripheral effects of the cardiovascular system that students will just be discussing in a short while. So this class was devoted especially to the mechanism action of the opioids and also the central action of the opioids. So thank you students so much. Keep on subscribing to this channel, and I would like to remember all our students, they are so much sincere in their work, and they are so much listening to the classes attentively. And yes, you have to be very, very self-motivated to listen to us in the comfort of your home. And I don't see any reason you will let me down. Thank you so much, students.